the tumor multiple myeloma, and he said that we should not call it a tumor of the red marrow collectively, and that we should specifically call it a tumor of the plasma cells. So he was the first one to recognize that this was a tumor of the plasma cells. So multiple myeloma is the second most common hematological malignancy. It affects about 35 persons per million. It has a median survival rate that increased over the past decade alone from 30 to 45 months. Bence-Jones proteins were later identified to be actually free light chains, and multiple myeloma is characterized by its excessive free light chain production. We know multiple myeloma can produce intact immunoglobulins. It could produce only just heavy chains or just light chains, but no matter what it produces lots of free light chains. The diagnosis, of course, of multiple myeloma is very important, because without diagnosing those people early enough, you'll just have to wait till they die and do an autopsy, and you'll never be able to treat them. Actually, the changes that have, the great improvements that have happened in those patients over the past 10 or 20 years are partially related to the rapid diagnosis. Diagnosis, until recently, only depended on protein electrophoresis. You find an M band, a monoclonal band, but of course this is not very sensitive. It needs a very high concentration of the free light chains or the free M band to detect. Immunofixation is a little bit more sensitive. Actually, it's much more sensitive, but it's very cumbersome, it's labor intensive, it's very expensive, and it is rather difficult to use for monitoring patients. Bone marrow, of course, finding plasma cells in bone marrow is the mainstay of diagnosis. It's how you definitely say that you have a plasma cell tumor, multiple myeloma, but it's not good enough, of course, for screening. And the first outbreak, number one, the first thing that you can do to improve the outcomes is to use the free light chain assays. Free light chain assays can detect light chains at very low concentrations. They're pretty cheap to do. You get the results on the same day. You can use them for diagnosis, follow-up, monitoring response, detecting relapse. They're very useful. If we still remember this figure that we used to study in medical school, this is an immunoglobulin chain. Of course, we know you have the heavy chains and two light chains in the fragment antigen binding there on your left-hand side. You will see that there are free light chains attached. There are light chains attached to the heavy chains. Light chains have two surfaces: a surface that is covered and hidden by the heavy chains, and a surface that is exposed. The problem with older assays is that they actually detected epitopes on the uncovered part of the light chain. This simply meant that you will detect light chains whether they were free or attached to the immunoglobulin, and you wouldn't know if they were free or not. The newer assays actually detect epitopes on the hidden side, so they would only detect the free light chains if they detach from the immunoglobulins, and they can tell you whether you have a free light chain or not. They cannot detect monoclonality. They don't tell you that you have a monoclonal band, but actually abnormal ratios can be very helpful in screening and making you suspect, actually with a very high specificity that could go up to 99%. There's only one pitfall that I really want to point out, which is what happens when you send this to the lab is they send you back the results and they tell you that the normal range is from 0.26 to 1.65, the kappa lambda ratio, which is true, but which is not true in patients with kidney disease. I don't want to go into the details of that, but just bear in mind that when you send a patient to do a kappa lambda chain to the lab and he comes back with a ratio do not look at the figure written by the lab. Actually, what you should respect is a ratio of 0.3 to 3. This is much, much more specific in patients with kidney disease. Meanwhile, in Nephroland, nephrologists were trying to figure out what was going on with patients with multiple myeloma. And in 1963, which is almost 100 years later, we started seeing reports of patients dying with acute renal failure because of multiple myeloma. At some point, about 50% of patients with multiple myeloma have kidney injury, 25% actually on presentation, 10% will require dialysis. There's a much higher mortality, that's around 40% within 3 months in the early reports of the 1980s. Higher mortality is related to so many things. It's related actually to the higher plasma cell burden that you have in these patients. It's related to the higher secretion of monoclonal proteins in these patients. It's related to treatment side effects and being unable to properly adjust the dose of chemotherapy in those patients. It's related to reluctancy among hematologists to treat those patients, and of course it is related to complications related to dialysis and renal failure. The median survival is about 1 year if the patient is dialysis dependent, and these improve they improve markedly if kidney injury is reversed. In one study, the patients who responded and had a renal response and the renal kidney function was recovered, had a median survival of 43 months compared to 8 months in patients who did not improve. And of course, it is unfortunately also correlated with poor response to multiple myeloma therapy in general. So patients with multiple myeloma and kidney disease don't respond that well to older forms of chemotherapy, at least. Of course, nephrologists love the word pathogenesis, so they went back to their lab and started trying to understand what was going on. And they discovered that the main villain was the free light chains. It is the free light chains. It's not anything else. This is what causes the kidney injury in those patients. What happens is there's deposition of free light chains in the tubular cells and the tubular lumen, among other compartments in the kidney, of course. This could lead to direct tubular injury. Free light chains from patients with multiple myeloma and no glomerular injury will inhibit membrane transport in cultured proximal tubule cells as well as in rats. In fact, not all patients with free light chains get kidney disease, and this is because the capability of the free light chain to produce tubular injury is related to certain peculiar epitopes and amino acid sequences on the free light chain that make it resistant to proteolysis. So when endocytosed by the proximal tubular cells, they just get concentrated, they crystallize, and they cause tubular damage. They also cause inflammation, which can be massive, with redox reactions, nuclear factor kappa B, with very, very rapid active fibrosis. And the main problem is they co-precipitate with TAM-Horsfall proteins, and they block the tubules. And when they get concentrated in the tubules, they cause lots of damage, lots of inflammation, lots of fibrosis very, very rapidly. And this is what we call cast nephropathy. So now you know the enemy, and now we have to go out to work. The first thing is speed. This is number 2. First thing we said, we want to find out and diagnose properly the free light chains. Number 2 is speed. Reductions of free light chains by up to 50% within 14 days can increase the recovery rate by about 80%. And this declines only after 21 days. I'm sorry, multiple myeloma is not a chronic kidney disease, and it's not just an acute kidney injury. Multiple myeloma is the most extreme drastic emergency in nephrology. I can't think of anything that supersedes it except perhaps antibody-mediated rejection and a few other things. But it is a very aggressive problem. So speed. Number 2, you have to avoid precipitation of the free light chains, of course, by hydration. Sometimes we give these patients diuretics. When the free light chains get concentrated, they will precipitate, of course. Hypotonic fluids are also important when you hydrate these patients because we normally give those patients saline, and saline can cause precipitation. Actually, the first case records ever of kidney injury in patients with multiple myeloma came from patients who received intravenous contrast. That's because intravenous contrasts are hyperosmolar, and they cause precipitation of the free light chains. So you should use half-normal saline when you hydrate those patients. You should also reduce the calcium levels because hypocalcemia, which is commonly associated with multiple myeloma, can cause precipitation of those proteins. Bisphosphonates will help you lower the calcium, and they seem to have some anti-myeloma effects. Of course, they're nephrotoxic, but they could be helpful in multiple myeloma. Alkalinization of urine, it has a biochemical rationale, but no clinical rationale so far. Colchicine is said to reduce the binding of the TAM horseful proteins to the myeloma proteins. There's no clinical evidence for that, but there's lots of rationale for it, so it's not a harmful drug, you can use it. So this is number 3. We detected the free light chains, we're going to act rapidly, and number 3, we're going to be rational when we treat our patients, and we're not going to do anything to harm them. Doctors are quite wise people. They like to sit down and discuss things and come up with inside-the-box sort of solutions. So they came up with the idea of reducing the plasma cell mass. And they started talking about drugs and chemotherapy. Steroids are actually very, very, very important. They probably have been and will be, I think, for quite a long time, the most important drug used for treatment of multiple myeloma. It has an anti-inflammatory effect to prevent the inflammation that we see in the kidneys. It has direct anti-myeloma effect, and using steroids alone can result in a 43% response rate alone without anything else. Almost half of your patients can go into remission. Conventional chemotherapy, by 1968, there were only 7 cases reported by 1968 of who recovered their kidney function. Patients with kidney injury following multiple myeloma don't recover or didn't recover their kidney functions at that time until this very nice report came out in 1968. And I'll quote, "The use of dialysis, a procedure which has seldom been employed in this condition, and melphalan, which induced a remarkable remission in the underlying disease." The interesting thing about this quote is that he actually splits them. He thinks that patients with kidney disease did well because they dialyzed, and the multiple myeloma did well because of the melphalan, which is actually not very true. Patients with kidney disease did well because they took the melphalan. They do well when you improve when you reduce the plasma cell mass and thus reduce the amount of free light chains produced, and when you do that rapidly. Until the early 2000s, the renal recovery rate remained at as low as 50% in patients with kidney disease and multiple myeloma, and about only 20% in patients who require dialysis. Very low figures. More recently, and this will probably be number, I can't remember by now, 4 or 5, the 4th thing that we should do, reduce the plasma cell mass using the novel chemotherapeutics. Bortezomib is a proteasome inhibitor. It has anti-plasma cell effect, very potent anti-plasma cell effect, but it also has anti-inflammatory effects. It inhibits nuclear factor kappa B. So not only does it reduce the plasma cell mass, but it also prevents the inflammation that they cause. It doesn't need renal adjustment. It gives a very rapid renal response. So far, we have recorded rates of 68 to even over 80%, and up to 30% in patients who are dialysis dependent. This is, of course, a breakthrough in the management of patients with multiple myeloma. Of course, you should do that rapidly within the first 3 weeks of presentation. Thalidomide with dexamethasone improves the renal response rate in newly diagnosed patients to around 70% and up to 60% in patients with relapses and refractory disease. Lenalidomide is a newer generation of thalidomide, which has a problem that it needs renal adjustment. But again, some nephrologists like to act like Superman, and they like to do out-of-the-box things, and they like to be heroic, so they took the dialysis machine and just took off and decided to remove the light chains from the blood by plasma exchange. There are so many small studies that you will find in the literature that tell you that plasma exchange is not that effective. Only a few will tell you that it's good, but the best studies we have so far are a study by Clark that randomized 104 patients with AKI to conventional or treatment or conventional treatment and plasmapheresis, and they found no benefit. In the MERIT study, which hasn't been published yet, but the data coming out are telling us that patients with severe AKI, creatinine above 5, receiving conventional, older forms of chemotherapy probably don't do much better when you offer them plasma exchange. Why? Well, actually, it's a very mathematical issue. Light chains are very small. They're widely distributed in body fluids. You find them in plasma, you find them in the extravascular compartment, and you find them in the extracellular compartment. Actually, only about 15% is present in the intravascular compartment. So when you do plasmapheresis for only 2 hours, you don't have enough time for replenishment of the serum after taking out the free light chains. But a brilliant idea came out. So who needs plasma exchange? You don't really need a plasma exchange filter with those very wide pores to take out those small free light chains. You can't do it with the regular hemodialysis membrane, but you can use something, a membrane with pores that are wide, not as wide as plasmapheresis, and you can start doing a session for 8 hours and give a chance for the light chains to be removed and then replenished from the extravascular compartment and then removed and so on. Actually, a free light chain removal with HCO over an 8-hour session can remove about 83% of the free light chains in the body, compared to only 13% from plasmapheresis. There's a single center study that suggests a 70% renal recovery rate just doing that. However, we still don't have definite evidence that this is going to be useful. We are waiting for the results of those 2 studies, the U-Light study, which compares high cutoff dialysis with standard dialysis. Actually, it's a 4-arm study, which is also studying it's just comparing that. It's the other study, the Meyer study, that compares high cutoff with standard dialysis, but also compares conventional chemotherapy with bortezomib. So it's comparing, the Meyer study should be comparing the ferrolite membrane. Should be very useful. It will be telling us whether high cutoff dialysis is useful or not, and it's going to be comparing head-on conventional chemotherapy with bortezomib. So basically, this is probably just number 5. We said that we want to diagnose the patients properly, fast. So we're going to use the free light chain assays. We want to treat the patients rapidly. We're not going to wait for the hematologist to start treating the patient after 3 months. Data from the UK registry tell us that patients get treated after diagnosis by 70% start taking treatment after 3 months, 50% after 6 months of diagnosis, patients with kidney injury and multiple myeloma. This is unacceptable. So speed is number 2. Number 3, try to be wise, hydrate your patients, don't give him unnecessary drugs. Step 4, give him useful chemotherapy, novel chemotherapy. And step 5, we're waiting for the HCO, high cutoff hemodialysis.